Victoria ma'am to give the keynote address on morbidly adherent placenta. Ma'am, please.
Thank you, Dr. Joseph. We've always admired you, not only for your presentation, but also the slides. I think amazing. Not only surgeries we've done, but also you really brought in a lot of new information on how to make slides. Thank you. Right, and now yet another topic where there is not only morbidity, but mortality. I'm going to talk on morbidly adherent placenta. The agenda of my talk would be to discuss the risk factors, the etiopathogenesis, what are the diagnostic tools that you would use, what are the ultrasound signs in the mid-trimester, in the early pregnancy, when would you use an MRI, and how and where would you manage these mothers with morbidly adherent placenta. So is accreta a man-made or a God-made disease? What do you all feel? Right? It's a Latin word which means accrescer, to grow from or adhere to something. So mostly it's been a man-made disease. The first series was described in 1937. A case series of 20 patients were described by Irving and Hertig, where he described abnormal adherence either in whole or in part of the afterbirth to the underlying uterine wall. And from 1937, we've been seeing a massive increase. So what is the pathogenesis? It was initially said that the Nitterbusch layer is absent, so the placenta goes and adheres, and when after delivery you need to separate this placenta, you cannot. So there is abnormal decidua, abnormal implantation, there is pelvic hypervascularity causing surgical adherence. So if you try to remove this placenta after the delivery or after the cesarean, the mother massively has torrential bleeding. And there are 3 types of placenta. Accreta, where the villi are just attached to the myometrium. Increta, where they extend into the myometrium. And percreta, where the villi penetrate the myometrial wall. The incidence, like I said, is increasing because of the rising incidence of cesarean sections, and this is a life-threatening condition, and certainly if you diagnose it antenatally, you could improve the outcome for this mother by reducing the hemorrhage. And it is said in this KMAC guidelines that the mortality from this condition is associated with failure to anticipate it. So if you're not ready, we have not diagnosed this condition, we try to pull the placenta once the baby is out, and this causes a torrential bleed, and the mother may collapse and die too. 20% to 50% of the past cases only are diagnosed today. So though we may not scan, at least if we are aware of the risk factors, what are the features we need to look at, and have those features been seen, then we have won half the battle. So the prevention care bundle for morbidly adherent placenta involves 3. One is the antenatal care, where you anticipate, where you plan, we counsel, and consent. That is half the battle won. The diagnosis should be made by imaging, and what are the modalities of imaging, we will discuss. And then you prepare correctly for the surgery. You have really done your service to this mother. So how do you improve the diagnosis? You have to be aware of the risk factors. And the 2 most important risk factors are previous cesarean section with placenta previa. You have to have a high index of suspicion. Send her to a proper scan center where every feature which can be picked up will be looked into, and we would diagnose. The other smaller risk factors are advancing maternal age, previous uterine surgery, especially myomectomies, multiparity if you've had done a thermal ablation, or uterine artery embolizations. So if you have seen all the cases of morbidly adherent placenta, at least one of these risk factors would be present in almost 94% cases. So this is the most important thing, that look at the risk factors. If there is placenta previa, if there's a scar, if she's had any surgeries, DNCs, do anticipate and do a careful scan, because the complications of morbidly adherent placenta are massive blood loss. The blood loss may go up till 5 liters. 90% of these mothers undergo cesarean hysterectomy. The other morbidity is because of ureteric injury, bowel injury, bladder injury, MICU admissions. So this has a lot of morbidity, and mortality ranges from 7 to 20%. So what are the diagnostic tools for morbidly adherent placenta? The first and foremost important tool is ultrasound, and both transabdominal and transvaginal ultrasound should be used in the diagnosis of morbidly adherent placenta. And in that also, you not only use 2D grayscale, you also use color, and if you have 3D power angio, it is good to use all the 3 tools to improve your detection rates. Elastography and MRI are some of the other tools that have been described, and we will see where they can be used. And it is said that the maternal outcome was better in women with a prenatal diagnosis. You could reduce the blood loss, you could reduce the hospitalization for these mothers when you are well prepared for this condition and you have monitored and managed this condition well. So what is the most important tool? This is a good meta-analysis which says today ultrasound is the first tool, because it's relatively inexpensive, widely available. You could repeat it without kind of allowing the mother to go through these MRI chambers. So this should be the first line for the diagnosis of PAS. And not only because it's very inexpensive or widely available, the sensitivity and the specificity of ultrasound is also fairly good. So now in 23, we've got a Delphi study of ultrasound signs associated with placenta creta. And what is Delphi? It is a robust consensus. Delphi study is nothing. So you look at all the signs that have been described, you go and look at all the cases of morbidly adherent placenta and see which of these were there, how many had this, how many did not have it, and then form a robust consensus to see which are the signs that you would want to look. And if these signs are present, how much is the sensitivity to diagnose? If these signs are absent, how much have you excluded? So this is what we would discuss. So in case you've had a scan and you have these doubt, you've found some lacunar spaces, she's placenta previa with previous section, refer her to our fetal medicine specialist, somebody who will do a better job, rather than just ask for an MRI and you're confused and the patient is confused too. So what are the ultrasound signs at mid-gestation? First is history again. So prior history of at least one cesarean delivery or myomectomy or PAS previously. This should be an indication for a detailed PAS ultrasound assessment. So if you have any mother who had an adherent placenta, or you've even done a manual removal of placenta, and now she has placenta previa, this is the mother you would refer. There are now 7 established standardized ultrasound signs in this Delphi consensus. They have also stressed the importance of a transvaginal ultrasound scan in evaluating the placental position and anatomy of the cervix. There are lots of new signs which have been described, which may become useful in the future prenatal evaluation, because now we are not only looking at diagnosis, we are also looking at how to prognosticate these mothers, where to operate these mothers, which are the mothers where you will not be able to do subtotal hysterectomy. Because now intracervical lakes, we are saying there's depth of invasion. So that is how newer and newer signs are being described. So what are the ultrasound signs? We will describe some of them to see. The first and foremost is how to look for the normal retroplacental space. So if you, how do I play this video? Yeah. I can't see, sorry, yeah. Right, so that's the normal retroplacental zone where you see the placenta, which is homogeneous, and there is a nice retroplacental hypoechoic zone, and then you have the myometrium. So this is the space you would see in all mothers where you're doing a scan. It could be an anterior placenta, it could be a posterior placenta. So you have this homogeneous placenta, you have the cord insertion, you have the normal retroplacental zone, and then you have the myometrium. So this, if you have seen, you're almost excluded a case of morbidly adherent placenta. So if this zone is absent, that means loss of this hypoechoic clear zone at the retroplacental myometrial interface, you can see this is definitely a case of morbidly adherent placenta. So this zone, you no more see that hypoechoic zone in all these. So that is the first sign, loss or irregularity of the normal hypoechoic interface. Then if you see abnormal placental lacunae, what are placental lacunae? There are large, irregular, hypoechoic, without a hyperechogenic halo. You see most of the cases, you will see it infarcts. When there is IUGR, you would see these hypoechoic spaces, but they have an echogenic rim. But in morbidly adherent placenta, you do not find that echogenic space. And depending on the number, the size, and the presence of it, where are they present, and depending on the vascularity, the probability that you're dealing with morbidly adherent placenta increases. So this gives you the Swiss cheese kind of appearance. So evaluate the placenta in all the orthogonal planes using 2D grayscale, and as the number, size, irregularity increases. Then the next sign that we would look is at the myometrial thickness. What is the myometrium behind the placenta? Normally, if you see, there should be a good myometrium, like I showed you in the normal. But if you have a very, very thin myometrium or hardly available myometrium, and look at it here, just behind the bladder, partially filled bladder, you just don't see any myometrium. Again, strongly suspicious. Then if you have an obvious placental bulge into the bladder, there is this entire uterus which is irregular, and you have a bulge which is protruding into the bladder, or the surface of the uterus is irregular. Again, you have the other signs also. You have the lacunae, you do not have the retroplacental space, the myometrium is thinned out. So each sign, already we have about 4 signs now. Then we look at the bladder wall interruption. You have this, normally you have this nice echogenic line which separates the uterus from the bladder, that is the serosa. But when there is placenta which is protruding through that, you will find that you have this placenta bulging into the bladder. So color Doppler, there are now, we have finished the grayscale. This we said is the normal, and look at this. So normally, the blood vessels are parallel. There is a chorionic plate, there is a basal plate. So the blood vessels run parallelly in the chorionic and basal plate, and you do not see many vessels crossing from the chorionic to the basal plate. But if you find very irregular, bizarre hypervascularity into the subplacental space behind the bladder, within the uterine substance, again, there is a strong suspicion. But there are 4 color Doppler signs: utrovascular hypervascularity, subplacental hypervascularity, bridging vessel, or there are placental lacunar feeding vessels. You again need to suspect. So we'll look at each of them. This is the utrovascular hypervascularity. And when you operate these mothers, you find that this is how the placenta looks. And even if you've not diagnosed it antenatally, it's good when you open the abdomen and you find this, you are on the alert, and you do not go and give an incision over this. So that at least, at that point at least, it's good to see, yes, it looks like a morbidly adherent placenta. Then subplacental vascularity, where there is a striking amount of color Doppler signal seen in placental bed, and this indicates numerous closely packed tortuous vessels. It's again like a neovascularization, like in a malignancy. So what do you find in a vascular when you are imaging any malignant part in the bladder or anything, in an ovarian tumor? You looked for hypervascularity. So that same hypervascularity you're going to see in the placenta. Then you may have placental lacunar feeding vessel, where you have vessels with high velocity blood flow leading from the myometrium into the placental lacunae, right? And they have a lot of turbulence upon entry. Now, what are bridging vessels? Bridging vessels are these linear dot dot. You have lines dot dot. These are vessels which appear to extend from the placenta across the myometrium and beyond the serosa into the bladder. That is, they are running perpendicular to the myometrium. These are the bridging vessels. If you have 3D power angio, you could use, because 3D power angio takes a sweep, and not only at the surface, what you're seeing with the 2D, you're going to see it within the placental substance, and you have numerous coherent vessels which could be easily seen in a 3D power angio. So you can see there is no uniform, disciplined arrangement of the blood vessels. There is so much of chaotic. The vessels are variable in size, number, caliber. So this is, again, a very, very diagnostic feature on morbidly adherent placenta. So what is the diagnostic performance of all these modalities? Grayscale itself has about 95%, so that's not an excuse if you do not have a color Doppler. Color Doppler certainly improves the sensitivity and specificity. Certainly 3D power angio, 100%. Now, what is the optimal gestational age to see this? First is high-risk situation. You could see it right from first to second trimester. But yes, these signs become best at around 28 weeks, and always examine the mother with a partially filled bladder. And when you finally see these signs, this is how we issue a report. We look at each sign and say, is it yes or no? And we give a score and say the probability is either mild, moderate, or severe. So it's always a good idea to look at, so no one sign is diagnostic. It is a constellation of all the signs that would go into the diagnosis, and then you can say, yes, good retroplacental zone, myometrium appears fine, there's no increased vascularity. The probability that there is morbidly adherent placenta is very low. Can we predict the estimated blood loss and mean units of blood transfused by doing an ultrasound? Can we guide the surgeon regarding how much is the depth of invasion? Does ultrasound also reflect the severity of the disease? Yes, like we said, we could look at these scores and say, yes, there's a very, very high chance that there is depth of invasion. So if you have a very, very irregular anterior wall protruding into the bladder, yes, you know that it has it's a placenta percreta, or into the parametrium, you know that there is an extent of disease is very severe, or into the cervical region. So then you know that there's a depth of penetration is high. There are new signs which tell you about the depth of penetration, and the first sign that has been described is the intracervical lakes. Can you see this? And that's why today TVS is also as important as TAS to look for morbidly adherent placenta, because this itself may be a marker of deep villus invasion and increased blood loss. Then another sign that has been described is the rail sign. That is like a railway track. And what they have done is they have looked at all the 4 features. And if all 4 features are present, this is described as the rail sign. And rail sign, when they have had a positive rail sign, it is associated with a 12, 9, and 4-fold increase chances of deep villus invasion, hysterectomy, and bladder invasion. So that is that means the blood loss that we shall have, the probability of bladder invasion, everything is going to increase if you have a positive rail sign. So do use the standardized terminology for PAS, and all the bodies today have recommended this. There is a prenatal ultrasound staging of PAS, which is recommended by FIGO. And this tells us PAS 0 is when there are no signs. There is placenta previa, but there are none of these ultrasound signs available. That is PAS 0. PAS 1 is when you have at least 2 signs, placental lacunae and loss of clear zone or bladder wall interruption. You call it PAS 1. PAS 2 is PAS 1 plus vesical hypervascularity. PAS 3 is PAS 1 and 2 with increased vascularity in inferior part of the lower segment extending into the parametrium. So why is the staging system needed? It is needed because as the signs increase, so is the depth of invasion going to increase, so is the amount of blood loss going to increase. So this shows good correlation with the clinical staging system suggested by the FIGO. How early can we diagnose? The signs, the lacunae and all have been described as early as 6 weeks. So if you examine a mother who's had a previous section, if you see a cesarean scar implantation, these are the women who may go in for. So what are the first trimester ultrasound markers? Always do a transvaginal. Look at the location of the sac. Do a detailed examination of the uterus in orthogonal planes to make note of the gestational sac, the placental location in relation to the bladder, the cesarean scar, and the internal os. So it's not just I think every obstetrician today has a bedside scan. So they just put the probe, see there is a sac, and say, okay, start progesterone, start folic acid. No. It's not important to just look at the sac. It is important to look at the size of the sac, the location of the sac, the number of the sac. And this location should be in relation to the internal os, in relation to the anterior or posterior wall of the uterus. And so always, always do it with a partially filled bladder and then only do a transvaginal scan. Magnify the area of interest to be able to see, because cesarean scar pregnancies are not uncommon today, and this sac may be embedded into the cesarean scar or outside it. So this is our case where we found the sac very low implantation. As the pregnancy progressed, you could see more and more signs, and by the end of second trimester, she had a full-blown. She was not willing for any termination when we found the cesarean scar pregnancy, so this is not uncommon today. What is the role of MRI? MRI is not essential for the diagnosis. Its use is limited with the cost and availability of the radiology experts, but it is more useful in posterior placenta, placenta percreta, or when you have morbidly obese mothers, and there are MRI features which are described. Elastography is available on many of the scan machines, and it seems to be a promising tool. So always optimize your ultrasound diagnosis by full bladder, transvaginal approach, evaluate real time, add color Doppler, and carefully assess the lower segment and the cervical return. Once you have diagnosed, what do you do? You've just diagnosed, or you have this mother. What do you do with her? Where do you refer her? When do you refer her? Do you give her steroids? How do you improve her hemoglobin? When to admit? Role of routine cystoscopy, stent, insertion of balloon catheters. Do you use a routine intraoperative ultrasound? What surgery have you planned? So these are all the questions you must answer when you're faced with a case of morbidly adherent placenta. And because there's paucity of appropriate evidence for the optimal management, you have to really look for help. The management, the first thing in the management is refer or transfer to a center which has the expertise and experience to handle this. Hospitalize them around 34 weeks. See that they are not anemic. Do arrange for blood and blood donors, because sometimes they need even 6 to 12 bottles. Plan your uterine conservation versus cesarean hysterectomy based on the ultrasound findings. Plan your tamponade, and around 34 to 36 weeks you can plan. And the team would consist of all these people: the interventional radiology team, the hematology, ops anesthetists, theater, ops surgeons, neonatologists, and HTU. So that's the kind of center you would need to manage these mothers. So they have to be cared by a multidisciplinary team who has expertise in complex pelvic surgeries, specialist center with immediate access to blood and blood products, where they have adult and neonatal intensive care. Always discuss with them the possibility of the need for hysterectomy to control bleeding. See that their hemoglobin is more than 11 grams when they enter the theater. The treatment may be cesarean hysterectomy, or they'll retain the uterus and retain the placenta and do it a delayed secondary hysterectomy, or triple P procedure where there is a conservative surgery is also practiced. Timing of delivery is between 34 to 36 weeks. Different bodies have given, but suffice to say, if they have crossed 34, give them a dose of steroids, and then you can. So the management and outcomes of placenta, accreta, increta, and percreta, how have they been managed? antenatal diagnosis would be the first thing. It has reduced the levels of hemorrhage, reduced the need for blood transfusion. Preventive therapies for hemorrhage have been planned and less likely to have, so you don't pull at it. If you already are prepared, you don't pull at it. Always, always correlate your imaging with histopathology. Send this uterus, look at the depth of invasion, because then the ultrasound people, the clinicians, the histopathologists have to know what is the level of invasion. To conclude, previous section, always try to locate the placenta or the sac if you're doing the early scan. If placenta previa, anticipate, detect adherent placenta. Ultrasound would be the first tool. Color Doppler would improve your detection rates. MRI has a high predictive accuracy. Always plan with the senior multidisciplinary planning is indicated, with pre-delivery discussion of the possibility of need for hysterectomy to control blood, this thing. But if I leave with a message, I would say attempt to reduce the first cesarean. We could avoid all this if we avoid the first cesarean. So when you do a cesarean, always think, is this needed? Can I wait? So if we reduce the first cesarean, we are saving mothers' lives. With this, I end my talk. Thank you.
Thank you very much, ma'am, for once again gracing